I want to tell you a little bit about adult celiacs in follow-up because when I was starting in celiac disease in the summer of 1981, when we had in the country only 400 or 500 celiacs, I thought celiac disease was a childhood disease. And when my professor told me about a certain patient, 20 years old, with ulcerative colitis, Chris, you have to think about celiac disease. I told him yes, but I thought he is an idiot, because that's a child. And a week later he asked me, Chris, and what about the celiac disease? And I said, no, I don't think it's worthwhile to do a biopsy. And he told me, I didn't ask you to think, I did ask you to act. So I had to biopsy and had to tell him 2 days later that was total villus atrophy. And then I had to make an article out of it, a case report, and then 3 weeks later I got an invitation of the Celiac Society of the Netherlands, that they were very happy with my proposal to lecture about underdiagnosis of celiac disease in the country, and since then it's a self-fulfilling prophecy. But okay, so I'm now an expert indeed, but at that time I wasn't. So what's to say about adult celiacs? We're talking quite a lot in these sort of meetings about diagnosing children, prevent CD, beautiful studies, but is it a major problem? I think it is. The problem in diagnosing is not that much. We're doing much better, and of course there's still a problem. But the major topic in my out clinic is preventing complications in celiac disease. And I'm not talking about the so-called refractory celiac disease, because that's very rare, but I talk about daily care of those patients. And as a matter of fact, we don't have guidelines for this. This is an expert idea about the whole thing, but we have to make a guideline about this. In the past, of course, celiac disease was rare, incurable, but now we realize it's quite common. But what to do with all the celiacs in follow-up? We heard this morning already about celiac out clinic led by dietitians. Good idea, why not? I hate the idea that GPs are doing this, and the reason is simple. We have in the country 30,000 diagnosed celiacs, we have 10,000 GPs, and if you would send back to the GP, they have a knowledge about 3 celiacs, and that doesn't help those 3 celiacs in the out clinic. So the whole thing is, what's going on with celiac disease? Well, it's not a childhood disease. This is age of diagnosis of a cohort of more than 10,000 patients in our country in the last 10 years. We do diagnose children, why not? But the majority of them will grow up, will be adults. As a matter of fact, the problem is here, between 40 and 60. There's where we diagnose the majority of our celiacs. But we still diagnose substantial number of so-called very old people. The major problem in diagnosing females around 50 is that they running up to the postmenopausal state, and if you come with fake complaints to your GP, they will say, yeah, hormones, you know. So the delay in diagnosis is here. And a lot of tragic stories I see in the out clinic. But as a matter of fact, if you look to this cohort, you will understand that the majority of my patients in the out clinic are adults, and the majority are above 50 years of age. And of course I see a lot of children in transition, and we can debate with the pediatricians if the transition should be at 18 years or 14 years or 16 years, but sometimes they come over to me at the age of 10, sometimes at 20. So the majority of new celiacs is 50 years or older, and that's not only in the Netherlands, the majority of countries. And then we can talk about, is this mistaken for years, but I think it's true that you can develop celiac disease at any age. Another problem nowadays among the celiacs being diagnosed is obesity. 40% of our new celiacs at diagnosis have a BMI above 25, which means that the majority of a substantial group of our celiacs is obese. And then if we diagnose them and they're underweighted, they have to fight obesity based on gaining weight after starting a gluten-free diet. So obesity in daily life is a problem. And this is also an interesting family. His mother was diagnosed at the age of 85, first celiac in the family. And then, of course, the whole family was talking about the small children, not about the others. So the grandchildren were diagnosed, and subsequently the others. And when they went to their GP, the GP told them, "You're too fat to have celiac disease, so we don't do TTG." And why not? And all of them had celiac disease and severe celiac disease. As a matter of fact, she has rheumatoid arthritis, and she had total villus atrophy and major problems. She was refused by GPs to be tested because she was obese, according to his definition. I don't say that you have to check all obese people in this country, of course, but okay. So if you run these sort of out clinics, you face new problems. Obesity, I don't think we operate our celiacs for obesity, of course not, but you will face new cancers in obese celiacs. That's also a problem of tomorrow. So it means new problems. The other thing is about malignancies in celiac disease. We recently finished a study about major cohort checking more than 200,000 people with lymphomas in the country for underlying celiac disease. And the odds ratio for enteropathy-associated T-cell lymphomas is very high. I think for celiacs above the age of 50 years of age, the chance of developing a T-cell lymphoma is around 1 out of 30. So it's still a very high chance, and the majority of them we don't see because they die based on the perforation, tumor mass, etc., and they can't come for additional treatment. But we were stupefied by the numbers, as a matter of fact, in the country. And this is not only patients who don't adhere at the diet, it's also patients who are on the diet for 30, 40 years, doing very good. Of course, you see more T-cell lymphomas in people who don't adhere very good. The other thing we found were small bowel cancers, a little bit elevated, and a remarkable esophageal squamous cancer. But we have seen last year's more and more reports from Iran and Turkey where they find the same among celiacs. I don't have any explanation for this. And we see a little bit more non-Hodgkin lymphomas. And of course, Joe West did publish about breast cancer, and we can debate about the colorectal cancer, if it's normal or lower than in the controls. But as a matter of fact, celiac disease is also protecting against some cancers. So causes of life, of death in the celiac population compared with the general population, it doesn't, it's matching quite good. But you have to realize we give care, it's our profession, it's our business taking care of celiacs. So we find in some of the celiac, based on the fact that they come every 2 years to us, we find earlier manifestations of cancer, so we can operate them a little bit earlier. So the other thing is what to do in the out clinic. Are all celiacs the same? Are all celiacs equal? I don't think they're equal. I think the people diagnosed as children are very easy to handle, run into less problems at elder age. Persistent villus atrophy is a problem in people diagnosed as adults, not in the children. I see very rarely those people. I see more problem in patients being diagnosed with a total villus atrophy than partial villus atrophy as adults. I see persistent villus atrophy quite a lot, and that's not refractory celiac disease. The slow responders, we call them, and you have to give them much more calcium. You have to substitute their folic acid much more, vitamin D than the others. So we have a different approach for different celiacs. Yes, we do. Then the whole thing about diagnostic criteria, and we can talk for hours about it when it's a celiac, but what's the problem in, let's say, a type 1 diabetic who has completely normal serology but abnormal antibodies? Well, in general, with other autoimmune diseases, I give them a gluten-free diet. It's not evidence-based, of course, it's not as clinician expert-based, so to say. Then the whole problem, and mentioned also by Marios about TTG, which antibodies we have to do. As a matter of fact, there's no standardization of TTG antibodies. We don't talk in the articles about the specificity and the sensitivity. It was a very nice article published by Govind a few months ago about the tandem approach of antibodies. A very sensitive TTG antibody with less specificity as first screening and second screening, a very specific, less sensitive TTG. We need data, we don't have them, also for follow-up. So different follow-up for different celiacs, I think so. Dermatitis herpetiformis was mentioned. Unfortunately, she is the one and only who is doing proper research in these sort of things. We lack those people on stage in the international congresses. Nobody's talking about DH anymore, but it's a major problem also in my out clinic, overlap with psoriasis and the whole thing. Then the gluten ataxia, and I think the work from Sheffield is fantastic, but I would prefer at the moment neuroceliac as name for it. Then the problem for India, from India, about non-cirrhotic portal hypertension. At first presentation, is this maybe hepatic celiac disease? What's going on there? So organ-specific celiac disease, does it exist? I think yes, it does. I have an idea that it exists. Follow-up in general, what am I doing? Are all celiacs equal? Well, I don't think so. I do a DEXA scan in all of them at diagnosis. And for research, we start at the age of 20, but I think 30 years of age is a good age to start with. In the past, we did colonoscopy in all our celiac. We didn't find anything. We still have to publish that, but okay. And we now refer them and tell them that population screening is excellent. But in all celiacs diagnosed above the age of 50, we do a CT. And I'll explain you a little bit later why. And matter of fact, the main reason is looking for the spleen, looking for atherosclerosis, based on the fact that if people have long-lasting folic acid deficiency in the years before, you are more, it's easier for your body to develop atherosclerosis. But in matter of fact, we lack data about our attitude, and we need more evidence-based data. So, in the first thing, I discussed with my newly diagnosed celiacs about the weight. If they're underweight, I tell them what weight I would prefer for them. If they're overweighted, I have to advise them to go down a little bit. So prevention of overweight is a major topic in my out clinic. Disappearance of fatigue, that's the quality of life, is a major, major issue. In general, if you're diagnosed as a female with fatigue at the age of 30, it does normalize a little bit, but the majority of patients will go on with those sort of complaints. If you're a female diagnosed at 50 with chronic fatigue as presenting system for celiac disease, they don't normalize. Males do much better, but if you're diagnosed with fatigue over the age of 55, it's also a disaster. And I try to have them do mucosal healing in all, especially diagnosed above the age of 40. If I see those delayed diagnosis, of course we see major problems with collapsing vertebrae, and we are very aggressive. We don't wait for the gluten-free diet to do their job. We give them prescriptions. Come back to that later. So we give all of them calcium, vitamin D. We keep the vitamin D level above 100. In the past we gave a lot of bisphosphonates intravenously, because if you have hampered mucosa or oral bisphosphonates don't work. Simple message, they don't work. They don't work good enough. And bisphosphonates intravenous will cost you £10 per year, and of course some daycare costs, but that's it. And now, as you have zoledronic acid once a year, as generic, will cost you €40. There's no problem with compliance. You give it intravenously, and that's it. That's for the next year. But we need trials. Of course, we need trials. Then the other thing about CTs, this is a new celiac, well diagnosed, already mentioned in literature by Corazza in the 80s, but we completely forgot. And this is a liver, this is some vessels, this is vertebra, but here should be a spleen. There's no spleen. And we see this quite a lot in celiacs. Small spleens, below the volume of 100. We described that compared with controls kidney donors. And we see disappearing spleens, but there almost no literature about spleen. What are we doing in hyposplenism? Well, demonstrated in literature that you're a compromised host. So we arbitrarily vaccinate them if they have a volume below 100 cc with meningococca, pneumococca, Haemophilus. So we are aggressive in these sort of things. Then the other thing on the same CT, you saw atherosclerosis. What to do in a guy who's 50, or he or she? Well, we think it's part of the atherosclerosis thing we have to do. So atherosclerosis is probably more manifest in celiacs. We have to work on this. Lack of data. But in general, we treat those patients with aspirin and statins with a much lower threshold than the control, so to say. And there's good literature also about it, that something is going on, but not that much interest in literature. So celiac and atherosclerosis, low threshold for aspirin. We try to keep the cholesterol much lower, and that's our attitude. Then, as I told you, not all celiacs are the same. It's about gene dosing. We described that already 10 years ago, 12 years ago, about DQ2 homozygous patients have a higher mortality. So in the out clinic, you should be aware in certain symptoms with those patients. DQ2 heterozygous has much lower risks, we think, at the moment. So then the whole thing about the second biopsy. I'm a believer of the second biopsy in the elder population to recognize the slow responders much better. Then the whole thing about gluten ataxia. I'm running now in gluten ataxia. I can tell you for hours, or not as long as Marius about it, but I can also lecture quite a lot. What we are starting to realize is that probably serology, TTG6 antibodies are important, but we think, and I made a mistake in the slides yesterday, but this is a Purkinje cell and also mentioned by Marius, but these are cytotoxic T cells we see now in the cerebellum of those patients. I'm collecting, new message, I'm collecting brains of celiacs, healthy celiacs, neuroceliacs, and of course I don't want to take biopsies of them, but if they are so charming to mention on the last will that they donate their brains, that would be nice. We have now a project in the Netherlands that the Dutch Brain Bank is people who volunteered for this, and we have around 100 people on the list above the age of 70, that the Dutch Brain Bank, if people die in a local hospital, outside a nursing home or whatever, and part of this list, they pick them up, so to say, take out their brain, and we look for it. And what we are seeing is cytotoxic T cells at this place taking in, replacing the Purkinje cell, not only the Purkinje cell, also frontal brain, also in the myelin. And based on this, we have now treated in the last year 5 patients very aggressive with a rapidly progressive neuroceliac disease, transfer myelitis with cladribine, high dosages, and prednisone, and maintenance treatment with thioguanide. So I don't wait for the gluten-free diet. I think we have to crush those cells. So then the other thing, what are we thinking about beer? All my celiacs want to drink beer. I tell them in general, lagers are good, and of course we test the Dutch beers, and I don't want to advertise them. If you don't want to support our economy, it's good, then you can support Danish lagers, but in general there's very, very few gluten in it. Dark ales here are terrible, full of gluten, but your local lagers are probably as good. So this is something about the beer. So in conclusion, I try to improve mucosal healing. Celiac disease is so much more than malignancies, and of course mortality is related to pre-existing damage. And I was dreaming when I give this presentation 2 years in Iran, and I modified this of course, that we would have ESG guidelines for this last year, but I think it will take another few years. Thank you so much.